Okay, it's 1 o'clock. I think we ought to begin as we have a full program. I'm Richard Cash, your host for today's discussion. It's a particular pleasure to introduce today's speaker, Victoria Fan, who is going to speak on the mitigation planning and politics informed by COVID-19 modeling, looking at a framework for the state of Hawaii. And then we'll also speak on lessons that are learned from this experience for low and middle income countries. It's particularly a pleasure to introduce Victoria, who is one of our own, as they say. Victoria got her mechanical engineering degree at MIT in 2006, and in 2011 got her doctorate here at the school in health systems. She's had multiple experiences in India and Taiwan. Most recently, she has been the associate professor of the Center on Aging at the Thompson School of Social Work and Public Health, and the interim director at the University of Hawaii. She's also, of course, had a visiting assistant professorship here at the school. Presently, she is a senior fellow at the Center for Global Development based in Washington, D.C. This whole event came about because Victoria and I were chatting when she was up here in Boston, and she was telling me about what had gone on in Hawaii, and I felt that this was that there were some lessons here that were very important to the local and global community. So on that note, Victoria,
thank you very much.
You.
Hi everyone, aloha, as we say in Hawaii. It's a pleasure to be back virtually presenting with you all at my dear alma mater, who I have a lot of affection for, and great to see old friends and new ones as well. So thanks for taking time out of your busy day to hear me talk about the small state of Hawaii and some of the work that we did in terms of modeling and how that informed the planning and policies in the state, and hopefully have an open discussion about some of the lessons that would be relevant for low and middle income countries. So what's the problem? Well, as many of us saw, the use of these mathematical and epidemiologic models really proliferated during this pandemic. And many models, or maybe even most models, weren't created with the explicit audience of policymakers or the intention of necessarily informing specific scenarios, or even the explicit communication of those assumptions, limitations, and complexities. And that's a big challenge I think that we as scientists face, is that we sometimes are so interested in the model itself, but if the ultimate goal is policy influence and policy engagement, starting from that sort of perspective can really change the way we communicate this very technical tool. So just to give you the highlights of what we did, it's now a historical perspective, but I'm going to just walk you through some use cases in the state of Hawaii of how we use modeling to inform policymakers, but also the media and the public about COVID-19. Just to give you a quick, really basic framework about thinking through the modeling on the surge up and also on the decline down. And then I'll just walk you briefly through some specific use cases where we applied modeling and fed into specific decision making. So one is in terms of assessing whether we had enough hospital capacity. The next is in terms of isolation and quarantine capacity. And then the third was sort of the broad and direct communication strategy that we took. I've put a disclaimer here at the bottom. Warning, this is not a policy, this is a policy paper, this is not a statistical analysis, there's no causal parameters. I'm not going to show you our compartmental model or agent-based model, anything like that. It's at a level sort of on top of that, which is the policy and communication of that model itself. Okay, so just again, like if you only have 5 minutes and just want to hear the key summary before you have to run off. So some of the key lessons are that states in the United States need locally tailored models and also local experts to help best inform these policy decisions. So there's an importance of local evidence. In Hawaii, we also saw the importance of what we call the brain trust, or a scientific advisory group to help inform and build these COVID forecasting models, but also to communicate it to the public. And we learned a lot about how to communicate, how to reduce confusion, and how to increase trust when we're communicating these mathematical and epidemiological model results. And the lessons for us in Hawaii were, importantly, one, limiting the time horizon, two, focusing on the dynamic nature of the model, how human actions, policy actions, individual actions can greatly change how the epidemic perform, what happens, and so thus the model itself is only a snapshot in time. And then also limiting our role to forecasting, assuming no changes whatsoever, rather than making recommendations about whether policymakers should do X policy or Y policy. And I'll get into some of the rationale to maintaining more of a neutral sort of meteorological approach, as opposed to getting into the fray of what government should or should not be doing, which is not to say we didn't have our own opinions, but there were sort of deliberate reasons why we chose to try to stay as neutral as possible. Okay, so here's an outline of what I'll be talking about, but just briefly in terms of the framework. You could think of different approaches how you might be using modeling, but in Hawaii there were sort of these two general categories or buckets of how modeling was used. So the first was on the surge. So do we have enough resources in terms of hospital beds, ventilators, PPE, medications, isolation quarantine facilities, contact tracers, other health workers? So this is a direct policy decision in terms of responding and mitigating the pandemic. And then on the decline, well, what measures need to be maintained? What can be dispensed with? And sort of these are the sort of two buckets of direct policymaker questions that we repeatedly received throughout the course of the past few years. Okay, so just a little bit about our local context in Hawaii and a little bit of background. As all of you know, US did quite poorly in terms of COVID, with just an enormous number of cases as well as deaths. And this is just in comparison to just say Anglophone countries, just as a comparison. And yet within the United States, there's also tremendous diversity as well. And the Commonwealth Fund did a ranking of states, and Hawaii performed #1 in the country. We're really pleased to see that. And if you break it down further, Hawaii had, I think, the lowest number of excess deaths across the U.S. states. Okay, I'm not going to get into a paper of trying to disentangle what drove these results across the states. I'll leave that to one of you clever, very, very smart people to try to get the different contributions and proportions of the different pieces that contributed to these different outcomes. But truth is, Hawaii did quite well. And I think more work can be done to try to unpack what that is. And so our work with modeling, I think, is just one small piece to contributing to pushing this number down as far as we could. As the pandemic sort of timeline rolled on, I get a little bit of PTSD as this whole timeline process happened. We were tracking, of course, all the international policy actions that began. And at the same time, locally as well, we've started to track every single policy action that happened locally. And this also informed our local model that we tailored for the state. But if you recall, early 2020, just as the information about what was happening in Wuhan started to come out, of course, none of us had any idea any of this would happen. But in the state of Hawaii, and I think in many places, we started to see in 2020 just a lot of confusion about data, right? So all the data and in the state of Hawaii was really bad data. Like we were using fax machines for contact tracing and all the case reports. There were all sorts of problems with the numbers and how that was able to influence policy decisions, all sorts of data problems. I think never before had the public demanded to know more about health data and this real-time health situation response. And I think David Canning once said to us in class that, wouldn't it be nice if health data was reported almost like on a timely basis, like the stock market, or something more frequent than being late 2 years, which is most health data usually has a 2-year lag. But I think for me, it was just a huge shock to see tremendous public interest every single day of what the new COVID case numbers were. So I think overall, this COVID pandemic, we all saw this crisis that was occurring. But in Chinese, there's a word called weiji, which has both a negative connotation, which is the threat or the danger, but there's also a slightly positive aspect to crises, which is there's an opportunity. And so for us in Hawaii, we saw the crisis actually as an opportunity to try to do something in response to the dangers of the pandemic. And at the University of Hawaii, we built and partnered with the state of Hawaii on multiple data products and dashboards in the public interest, of which this COVID forecasting was one of them. And if you go to www.hipem.org, you'll see our Hawaii Pandemic Applied Modeling work group forecast. It was launched in July of 2020 and provided ongoing forecasts for the state of Hawaii from the get-go. And what we did was, actually, this is something I learned here at the Center for Global Development, was the importance of a work group. We're so used to interventions that are like bed nets or drugs, but I think a work group is actually an amazing intervention to do. And what we did in this work group was we convened different stakeholders interested in modeling. And it started out that I started getting phone calls from different policymakers, the Department of Health, university faculty members, all asking me about modeling. And I thought, oh my God, if we don't bring all of our limited resources all together in a group, is going to be chaos, because there's going to have different models, different messages, and lead to confusion. So this group was established in April of 2020, early on in the pandemic, to get people together to think through how we as a sort of scientific volunteer community could try to use, science and evidence and knowledge, however evolving. Of course, COVID is constantly evolving, but use that information to best communicate to policymakers and to the public. And so our COVID forecast had these 4 key graphs in terms of cases and fatalities, and also hospitalizations and ICUs, which was, I think, one of the primary focuses of a lot of policymakers. Okay. So that's an overview of our work group. And actually, we were encouraging of all models. We didn't say that one model is the best model necessarily. We welcomed many different models to be made. And within our work group, we had physicists and mathematicians and computer scientists, each making their own model for the state. And we said, fantastic, everyone just make your own model. And then from there, we'll pick what we think might be the best one for the state. So in terms of the model selection, I think early on, well, first of all, let's get into definition of what a model is. So this is, as we all know, a mathematical representation of the biology and epidemiology of disease transmission. And in the state of Hawaii, our local policymakers were driven largely by media reports from the dissemination of models from the IHME and Imperial College model. So that prompted a major policy discussion locally, where we would get asked, hey, there's this model that's come out. What do you think? Do we believe the results that there's going to be a hospital capacity overrun or not, for example? And if you recall back then in May of 2020, wasn't really feasible to sort of do a comprehensive review of all models, or we just didn't have time or resources. They needed a decision, the next day or just in a short period of time about what do we do about the hospitals. And so we had to just be practical. We had to pick models that we thought were relevant. And so what our team did, of sort of this work group did, is we were advising policymakers by just very selectively using the tools, whatever tools that were available publicly at the time. So in early 2020, whatever was publicly available, we tried to glean best practice and lessons from them. It's not like today when you go to the CDC COVID modeling page, there's like 30 different models out there that you could pick and choose from. Okay, so this is sort of the ex-ante criteria that we looked at. What was the model built for and designed for? Can we tailor the model to our local parameters? Does it incorporate local age distribution? Seems like a really basic question, but oftentimes not necessarily incorporated. What type of model is it? Is it a stochastic or mechanistic model? And importantly, is it an open source model? Can we open it up and look into the hood and see what's going on? And these were the main criteria that we used to say, hey, well, maybe a model from a different university might not be relevant because they're not using Hawaii's age distribution, and we also don't know what's driving the model. And instead, we recommended a different model. I think at the time it was a Johns Hopkins model that we were able to tinker with and play with. So at the time, like I just said, there's no predictability results that you could say about one model being better than the other. And it was really about ex ante characteristics to justify to policymakers why we thought a model from one university might not be so relevant for the state. And now I'm going to just shift over to some of the specific use cases of the modeling. And I've just hinted at one of them, which was this urgent question in May of 2020 about, do we have enough bed capacity and PPE? Second one was in terms of the isolation. Do we have adequate isolation and quarantine facilities? This was in the second wave. Hawaii had a second wave in the fall of 2020. And then the third use case was really in the Delta surge in the summer of 2021, where we decided to take a much more public approach. In 2000, we were very much behind the scenes. We saw, I think, a lot of the mistakes and confusion that was driven by some of the modeling, very, very national public modeling, and we were fearful of the mistrust that might be created through the scientific communications. In 2020, we took it more like a pilot where we were talking with policymakers, had communication, and could see where they were getting confused. And that also informed in 2021 how we changed the way we kind of communicated. I put an asterisk here to just say these are 3 selected use cases. There were several other use cases, but these are the ones that I can talk about publicly. Okay, so in terms of the first use case on hospital capacity, we all know IHME was one of the few models providing state level information, and it was a hugely important resource because it prompted that discussion. And of course, many of us will be critical of the IHME models because they're very, very much wrong in certain cases. But I still think there is value to having something wrong in the sense that it prompted that conversation. It prompted the state level policymakers, the governor's office, mayor's office, to ask locally for expertise about, hey, can we believe this? And if not, what should we be planning for? So it sparked that hospital capacity planning decision. As we all know, the initial IHME model had a couple of deficiencies, couldn't incorporate local parameters or local age distribution. It was a statistical model. It wasn't it wasn't like a compartmental model, and it was not open source, and you couldn't customize it. So we had a different model. I think it was a Hopkins SEIR model, and we argued at that time to the then emergency commander, the general, that we were not going to be seeing the surge that IHME had predicted, and that there was probably no need to retrofit a stadium for additional acute facilities, saving us several millions of dollars in costs. So that's a very, very specific use case where we said we don't need to believe that this model. We built out another one, and our other model saying probably we don't need to worry about it. Okay, so that's the first use case. The second use case is in terms of isolation quarantine capacity. Hawaii got its second surge in the fall of 2020, and at that time, the health department requested the modeling group about guidance for how many beds they should set aside. And at the time, the beds for isolation quarantine were only for those who could not isolate safely at home, which meant that you had to have a private bedroom. Okay. And we needed a simple benchmark to identify whether you had adequate isolation or quarantine capacity. And we didn't have much time. They needed to know, like, they rolled out isolation quarantine, I think on August 10th, and they needed to know very shortly after how many beds they needed to sort of procure. And so we picked a benchmark. We looked into the census, and we saw actually 10% of Hawaii's population live in a shared bedroom. Maybe 10% of the active cases will need to be isolated outside of their home. It was just a very crude benchmark. And that was used to justify the procurement of, I think, hotel space. So at the time, at its peak, we had around 400 hotel beds in the state for people who couldn't safely isolate. Okay, so our third use case, and again, these are all fairly, I would say, innocuous cases. There's nothing controversial about them. There's no public hatred per se, or sort of polarization. They're fairly straightforward cases, and these are the ones that I'm sort of able to discuss publicly. But in the third case, this is when HIPEM took a much more public direct communication strategy. So we were anticipating the Delta surge. Probably in early July, we looked at the numbers and said, "Oh, this is gonna surge in about 2 or 3 weeks," and we, started informing the health department and the behind-the-scene channels. And then we got the sense that maybe, perhaps, nothing was going to happen. They weren't going to make any major changes, and so at that point, the work group decided to reach out very broadly. On an almost weekly basis, we started pushing out forecast reports. We were on the local TV stations almost on a weekly basis. We're on TV, radio, social media. We got called into state and county government hearings about the forecast. This was hugely different from 2020, where we were, like I said, primarily behind the scenes. It offered us an opportunity to understand how policymakers think and the kinds of questions that they ask us, and also how repetition of communication of messages was really important. We would often feel that we'd already told them, the model can only predict so much, and it's going to change once you change your policy. But they would still ask us things like, "Well, tell us what the forecast will be in 3 months," right? That was every time you met them. They would still ask us the same question, and we would have to go back to tell them, just as we told them before, no, that's not how modeling works. This COVID modeling really can only give us, at best, 1 or 2 weeks. So our group really tried to maintain that scientific credibility and public trust in every communication instance with the public and also legislators. I remember even in one meeting with a sort of a very influential policymaker, she had the report printed out and she said, "HIPEM forecast is spot on. And so we're really encouraged by that case. Okay, so some key communication lessons are in terms of neutrality. So given the tremendous polarization about both sides, people wanting to do more restrictions or less restrictions, we felt it really important to stay as neutral as possible. And rather than get into the policy recommendations or the scenarioing, or even, as soon as you put out a scenario, immediately we would be potentially accused of political bias for, like, are you suggesting we should do a lockdown, or whatever the recommendation was. So we just pushed all of that scenario planning or sort of different scenarios aside, and we just kept that behind the scenes, and we focused very narrowly just on unbiased business as usual forecast. Okay. And we also emphasized to the policymakers that this is just one piece of information, that they're going to need to make decisions on all sorts of other things to take into account, whether it's the economics, our local economy, tourism dependent, education. Those are all other things that they need to consider. Our forecast is just one of those pieces of information that they need to make a decision. The second key lesson was in terms of the time horizon and sort of the dynamic nature of the model. We really emphasized early on from July that we would only do 2 weeks and no longer than 2 weeks, even though we were constantly pestered by everyone. "Well, tell us what it's going to be in 3 months or 6 months." And we would constantly remind them that everything changes in 2 weeks, because after we tell you what this model tells, whatever the forecast is today, you're going to change your behavior. There could be a policy change tomorrow, and then the results are completely wrong. It's not going to, in fact, in some sense, we actually want the model to be wrong because we're telling you this information because we're anticipating you to change your behavior. And we also emphasize that new individual actions or policy actions from today, when we report this forecast, are not being incorporated into the model. So we were constantly reminding people that this forecast is if we do nothing at all, if we continue to do what we're doing, if this is just the business as usual case. And we also emphasize that there's some similarities like the weather forecast, but one huge difference is that individual and policy actions greatly influence the outcome. So those are some of the key lessons about what we learned in terms of those three use cases. But as I step back and think through more broadly some of the broader lessons for low and middle income countries, modeling, as we all know, is extremely complex. It requires a tremendous amount of subject matter expertise to use the data, interpret the data, communicate the results. We also saw the importance of local data and local customization, and also that the interpretation of the model is very complex and that we should focus more on the direction rather than any specific number value. So oftentimes whenever we gave them a number, we tried to avoid giving them a number that was far, if we're saying in 3 months, first of all, we never said anything in 3 months, but even in a month's time, we said on a trajectory upwards. So focusing on the direction rather than the specific numeric value, recognizing that the reporters and the media were always trying to find a gotcha moment, like, aha, well, your numbers were wrong. So focusing more on the direction. And then also, we saw the value of policymakers who were time sensitive to key decisions. It wasn't always the case that they were time sensitive, but when they were time sensitive to key decisions and they had the humility and foresight to seek information outside of their normal sphere, political sphere, we thought that the information that was provided could be quite valuable for decision making. Okay, some other lessons that we sort of found from our group is that having this interdisciplinary scientific advisory group can be so helpful. I think for the first time in 8 years at the University of Hawaii, I finally met physicists and mathematicians and computer scientists, all together, and just was an incredible resource that I had no idea that we had in the state. So in that sense, it was extremely valuable. We had also, of course, our health department and epidemiologists and health professionals informing the discussions. It was very much an interdisciplinary scientific advisory group. And we had a range of expertise, all people who wanted to do something for the state. We are in this pandemic and seeing the local economy going to tatters, and we wanted to do something for the best interest of the community. And the last was, there's an important role, I think, of local universities working in close partnership with the community and the government. And I think this is an important lesson more generally for low and middle income countries. Governments don't always have that technical capacity or expertise. And even in Hawaii, the local health department would tell us things like, well, we don't have expertise to do modeling. We need, the university to help us with that. Okay, so just some limitations of this case study is, it's not a research study per se. It's not a econometric study. We're drawing on lived experience, historical perspectives. There's no counterfactual. What would have happened if there was no modeling, local modeling group, anyone's guess. There's also constant awareness of the political context of the modeling. I can't tell you how pervasive this feeling was, and almost a anxiety that all of us faced was that whenever we came up with our forecast or had a report to share, we were constantly just fearful of what the public outlash and negative reactions might be, or even sort of the polarization might be. And so that definitely affected, I think, how we communicated the modeling. We always tried to stay as accurate and neutral as possible. And then again, as I mentioned, there's only selective public discussion of these use cases. I didn't discuss any misuse or misappropriation of models, although there were quite a few, actually. Maybe in 5 or 10 years I can write about those, but until then, we'll have to save that for another time. So some broader questions, I think, for low and middle income countries would be, how do we create and institutionalize bodies with this type of blended technical expertise and savvy communication with these linkages to policymakers? So I think universities are really good at that technical expertise, but are lacking the communication skills and also the policymaker linkages. So how do we create these institutions that have all of these blended expertise? And then how do we communicate in ways that builds trust in the public? I think this is an ongoing lesson for us in this scientific community. And then also, what is the role of local universities in bridging this gap between evidence and policy? And particularly here in Washington, D.C., USAID is talking quite a bit about localization. For me, coming from a remote, isolated place in the Pacific, what is the role of a local university in having that capacity for evidence, evaluation, and science. So some of the lessons, I think, more broadly for the US and low and middle income countries was we found actually that modeling, we would argue from our work group that modeling is a form of epidemic intelligence. And yet at the same time, we found that the disease investigators in the health department were not trained to do modeling. Most of them were Shula epidemiologists, really important in terms of contact tracing, but often had very limited expertise with data. Like we're talking, very large tables, let alone anything with modeling itself. And so I think this is an important aspect of this public health workforce and training, is that we might think of epidemiologists as within the university context as very technically and quantitatively trained, but in practice, I would say the public health workforce epidemiologists are much more the vein of shoe leather epidemiologists. So there's a kind of a gap, I think, in terms of the skill sets of what epidemic intelligence means. And even the Epidemic Intelligence Service, I would say, largely focuses on the sort of the shoe leather epi. Where does modeling fit as part of that? And of course, the CDC has now developed a new center on epidemic forecasting, led by one of HSPH's faculty members now on leave. So I think anyway, I think this public health workforce piece is something that we should really think through about who is actually staffing our local health departments. This big question of leadership for me was seeing how some policymakers were more interested in evidence and seeking evidence and data than others. Just like other states in the United States, decision making was very decentralized, whether it was county level mayors or at the state level, the governor's office or the health department or the emergency management agency, the adjutant general, and so on. So there's a large sort of array of different leadership, and we were able to see a huge variety of leadership interested or less interested in information. And then there's also bigger questions about how do we build this ecosystem, or how do we leverage universities working in partnership with the government and in media. And also for me, the agenda setting device of media was just phenomenal. Just seeing how IHME putting out this report nationally just sparked a local conversation shows to me how media, and it seems such an obvious point if you're in communications, but how media can be used to change the debate and the discussion. And for me, one of the big takeaways is policymakers only respond to the media. If there's a media thing, then they'll do something. Otherwise, they may not do anything at all. Okay, so what's a country to do? Well, I think it will vary quite a bit if it's low income versus middle income. Middle income countries tend to already have a lot of local universities. So, really strengthening and continuing to invest in those is really important. The story I like to say, this is a personal anecdote. I met a dean of a school of public health at the University of Indonesia, and she said, "Oh, you're from the University of Hawaii." Well, our first generation professors at the University of Indonesia were all trained at the University of Hawaii, and they all, when they graduated, they returned and built the School of Public Health. And it was paid for by USAID. And I was just shocked at this story that I'd never heard about USAID's important role in sort of workforce development and local capacity with a focus on universities. And I do think this bigger question of what is the role of foreign aid in supporting local universities really needs to be examined in greater depth. There's also an important piece of how local universities partner with governments as well. This is also true in the United States, but I think the ways in which government can rely on university partnerships, particularly public universities. So the state of Hawaii has a public university which is procurement exempt. So that means we don't have to go out for RFP if the state government wants to give the university funding. So there's some sort of advantages to working with a public university, and it could be better utilized to work in partnership towards public health or whatever the agenda might be. Questions about sort of international training, mentorship, but also an importance of communication training. How do we get scientists to be better at communicating something so complex and technical? I think is an area where we should really think more about. And then this broader question is about this foreign aid architecture and sort of the importance of capacity building, not just as sort of this helicopter fly-in technical assistance of 2-week consultants giving trainings at the hotel for 2 weeks, but how do we really build local capacity, both in terms of the workforce and our IT systems, and what is the role of the local universities in helping to build that local capacity? As far as donors, what should donors do? I really dislike this concept of technical assistance, this sort of paradigm, just as I said, of this helicopter fly-in approach. I think we really need to think through this local institutionalization of capacity building. And I think there's a lot of lessons that we should learn. I'm thinking of Jesse and the historians in the group here about drawing on lessons of, say, the Rockefeller Foundation or the China Medical Board and investing in universities, or even the University of Global Health Equity in Rwanda, and how that's very much linked this human resources agenda through the lens of a local university. I would argue that donors need to really think much more explicitly about local university workforce development as part of their current grant making and lending activities, not with research as the primary emphasis, which I know us being former, currently or formerly at Harvard, there's a big emphasis on research, but I would say actually universities have much more practical uses in terms of just evaluation or implementation, evidence synthesis, and even translation into policy. Donors could also think through ways that they could incentivize these international networks or the ways that are collaborations that are interdisciplinary. And donors might think about ways that, I think this discussion here in Washington, DC about the pandemic fund at the World Bank, there's big policy discussions about how this pandemic fund should be used. What does preparedness mean? And what is the role of donors, or so how should we spend this money for getting countries to be more prepared? And I think in that sense, I would argue that we need to really think much more carefully about this local epidemic intelligence capacity, both in terms of workforce as well as our data systems and IT systems. So that is a high-level overview of our case study in Hawaii, and would love to have a conversation with you all about sort of the broader implications about what a country should do and what should donors do. Here at the Center for Global Development, we focus quite a bit about what donors should do better, and would love to have a open-ended conversation. So that's it for me, and thank you so much for your attention.
Thank you very, very much, Victoria. You've laid out a very, very interesting set of discussion points. Before I weigh in, let me ask, are there any questions from the audience? You can use hand raising function or whatever you feel. Okay, well, we've got two right there. So Godars, why don't you start out?
Thank you. Good to see you, Victoria. Fantastic work, and good to see you again. I want to ask about you. You started, of course, by saying how these models could help policy, but also in the context of Hawaii and the politics of prevention, you limited yourself to short-term, under no intervention prediction and forecasting. Couldn't there be a middle ground by putting everything like 5, 6, 7 different policies from both sides of the political spectrum for interventions? And in that way, I'm hoping that the people who do this kind of work in LMICs, their context would not be as political. But this is sort of a sobering point where you build a nice model, you think you can do great work on prediction, but then you limit yourself to forecasting. That's a bit of a limitation, I suppose.
No, it's a really great point, and I should just emphasize that the 2-week time horizon forecast was what was shared publicly, and that there were behind the scenes scenarioing that was happening. There was also severe capacity constraints, like even just doing one scenario for us, we were just all volunteers. I had like 4 of the jobs on top of this, so we didn't have time to do too many scenarios. And it's one of those things where, like, if we had the leisure to do more than one scenario, that would have been great. But usually we just had time to just do one scenario at a time, and usually prompted by the policymaker saying, hey, this is the policy that we're considering, that, whatever political jockeying that they had come up with, and can you tell us what you think of this? Right? And that was sort of the behind the scenes policy discussion. But I think, absolutely in an ideal world where there's less time pressure, you would like to have that leisure to think about what you might want to do. But in practice, we just didn't have that kind of the time. It was just the urgency of the decision making was, we need to know what to do right now. Tell us what to do, right? So in that sense, it was tremendously stressful. But certainly for other areas, I think it could be applied, that, not to say are less urgent, they're as important, but maybe just less time sensitive. And COVID, just because it's growing so quickly that we didn't have that much time. Yeah.
Thank you.
Great question.
Nick?
Great, yeah, and thank you, Victoria. That was fantastic. I think it was insight into a process we very rarely get to see as academics. And so I liked your point about the work group in terms of pulling together people with disparate methodologies and maybe even values. And I can see that how that can make the results more robust. I was wondering how you dealt with disagreement in that work group, because I would assume that that's something that would come up a lot, potentially also due to this high pressure timeline. And I'm not sure how that would get resolved, if that's something you can speak to.
Oh yeah, absolutely. I mean, I think we had a spectrum of people who were wanting more restrictions or less restrictions, but we always emphasized on the model itself. Like in that sense, we avoided the discussion so much about the scenarios, and so people would come to the table with different models that they had made on their own overnight for fun, basically. And initially we had maybe 3 or 4 different models, but in the end, we all agreed that Monique Shiba, who's a mathematician in our university, had the best model. We all agreed on that. She had incorporated in extreme detail all of those policy measures that you saw on the screen on the timeline. So in that sense, there was broad agreement about the model. There was always disagreement about what should be done. Yeah, but like I said, the work group, had these 2 functions. One was the forecast, and the forecast sort of, they're different teams working on it, but in the end we had just sort of one technical team that did it. And then the sort of scenarioing, yeah, there were scenarioing discussions that we just kind of had by ourselves without a policymaker, and then there were the scenarioing with a policymaker asking us for a particular scenario. So and for those requests, we had very little time, so we actually had fairly limited engagement with the actual work group and the technical team to do that sort of conversation. But no, the polarization and then sort of well, I should say that there's disagreement and there's polarization, but I think the group was always respectful, and we always had a really good rapport early on in the work group. We kind of established relationships with each other. I think that in that sense, it was very respectful and very community oriented. And it was almost like a therapeutic session for all of us, because here we are, April 2020, things are locked down, and it became a venting session or a session of like baseball, like just tracking the numbers. And, it was sort of a group therapy in some sense. But no, I can see how disagreements can and often do happen in groups. But I have to say that creating a really strong group support and sort of respectful environment really made a big difference. So
I would submit, Victoria, that the Harvard School of Public Health could have used a work group, or could have been far more a part of our culture than it was. That's just an editorial comment. Shekhar.
I'll just add,
because you weren't on the work group.
just one more thing is that,
Right.
this working group approach is something that I learned at the Center for Global Development. There are some policy notes about how to do a working group, and if you're interested in doing a work group, I'm happy to share some of those resources with you about how to get that going.
Very good. Thank you. Shekhar.
Yes, thank you. Thank you, Richard. fantastic work, superb presentation, really liked it. My question is that at least for policymakers, being underprepared is more risky than being overprepared. And I was fascinated to hear that you could save them some effort, trouble, and also money. Do you think they appreciated your efforts on optimizing the preparedness and appreciated the fact that you actually saved them trouble and money or not?
That's a really important question, Shekhar. I would say it depended on an individual basis. There were literally at times comments that I received of, well, the modeling is not useful and we don't need your modeling, like literally verbatim. And other policymakers were like, this is so valuable. We need you to help us inform all of our decisions throughout and not just on these one-off bases. So it was very much individual and sort of leader specific, with better leaders seeing the need to build us in more deliberately as opposed to one-off or even just shunning us entirely. There were cases of that as well. I think did the state value us as a whole? I would say towards the end, yes, we did get some support from the Emergency Management Association. We finally got some money in this year of January. Until that point, we were all just entirely voluntary, but then the funding ended, and now it's dispersed. It's basically back to baseline, and we argued that there's a need to continue and maintain this capacity, that the health department should build a unit within the department to continue this kind of work. That hasn't yet happened. Still hopeful, but so much is we have an election happening in about 2 weeks, so we'll see what happens with the new governor, who's a medical doctor. So much is politics driven, but yeah, I think very much opportunistic and idiosyncratic on a person-to-person basis, and the ways in which we can institutionalize it and make it part and parcel of an organization is really, really crucial. Our work group is still just in the ether. We're just a group of people that we just meet once in a while, not actually funded with core resources or core staff by the health department or the university. So in that sense, it can easily came together organically and spontaneously, but also easily falls apart as well. So yeah.
Jesse.
Yeah, thank you. It's great to see you, Victoria, and thanks
Hi,
for a
Jesse.
great talk.
Thanks.
You were talking sort of in ways there's some tensions here about the way you're delivering this presentation, where on the one part there's some apology about not about modeling and these aren't econometric issues, but then there's some assertion that, and in fact, that we need to look at that more closely. And I'd like to encourage you to formalize this sense and call for a new, more inclusive epistemology of public health, one that recognizes the usefulness of different parts and can put it together in a way that is maybe more useful. It's public health, right? This isn't an abstract thing. It's an entire enterprise that's dedicated toward improving societal function.
Mm.
And models alone, they just don't do that, right? It's too much to expect. We as a profession are pretty limited in the way we consider these things, even in our invocation for people to listen to science as if it could speak on its own. You're really talking about the perception or the reliability or the evidence and all these things that come down to trust. So I was just wanted to ask you to sort of react to that and think about, well, if you need more inclusivity to generate more trust, what would it look like in or a methods perspective or an institutional perspective? Thanks.
It's really, really thoughtful responses and ideas as always, Jesse. Yeah, I think you hit it on the head in the sense that there's a sense of being apologetic that this is not a quantitative, rigorous research paper, which would meet the standards of the Harvard School of Public Health for promotion and tenure. It's just a lived experience. What does historical lived experience mean in the science, in the sort of notion of science, right? And in that sense, I do feel that the public health academic community undervalues this type of sort of implementation, let's call it real world policy making experience, sort of the political economy or this qualitative narrative experience. And that's partly the incentives, I think. You know, it's much easier for academics to publish research papers using data which doesn't have necessary policy involvement, because policy and politics is super messy, takes a lot of time, very complex, and you know, it'll mess up your research study. So, you know, you're not gonna, all of our models are wrong, because every time the next day the policymaker would just drop a new policy, and then, you know, what is it that you're actually studying? So I think the epistemology, so to speak, really has to do with the ways that universities incentivize or value knowledge, and also sort of influence. I got tenure at the University of Hawaii, you know, just about quantity of research papers for the most part, but the value of engaging with the State Department or the governor's office or the mayor's office had no plus points, you know, for tenure promotion, right? So I think that is a big piece that public health as an academic community should really think through. You know, how do we count up going on the news 40 times? Currently it's 0 points. So if we change the promotion incentives, I think that would change the things that public health academics care about. Unfortunately, there's all sorts of legacy issues, and people who are tenured professors tend to be not the ones who are engaged on the policy level. So maybe a bit of a challenge there, chicken and egg problem. But I think it's a really important discussion. I don't have the answers for it. I do think the value of this implementation research, if we're to call it that, you know, I'm not even sure what this is sort of qualitative, anthropological, ethnographic experience of having to talk to a policymaker and hear how they think, which is a fascinating way of thinking. I've not yet fully articulated it, but yeah, how we as scientists better engage with the real world is a big gap, I think, for sure. But we need some sobering reflections on, and the fact that science is in this very dire state of trust is a reflection of collectively all of us. How can we better communicate? So I don't know if I've answered your question, Jesse. We should have some proper
Marcia,
discussion separately.
yeah.
Good.
Marcia,
Victoria, just superb. We made us all proud. So I wish there were more
Thank you.
faculty and students here to see the great work you're doing. So quick comments. I'm not even going to comment on the public engagement, although I want to catch up with you later on this, because I have some ideas. But the first comment is we had recently here with us the former president and former director of the Social Security from Costa Rica, and they faced the same challenge. They had the model from Imperial College. They had their own model. Imperial College was, you know, much higher, and they had to make a decision. And it's fascinating to hear them describing how challenging it was, how afraid they were of making the wrong decision. And at the end, they trusted their model. And by there, I mean somebody that was working with them right from the beginning. And at the end, it was right. Their model was much closer to what happened. But they were fearing that they would ruin the trust that they had built from the beginning of the pandemic by choosing the model. And the second comment I want to make is, you know, if you take your last slide of recommendations for low-income countries, and you know where I'm going. I'm going to talk about Brazil. So Brazil had all of that and threw it all in the garbage. So they had, advisory groups that used to bring community scholars and everything working with the ministry. They cancel all of those. So we don't want to hear science pretty much. And there was a lot of the misuse, which you are only going to tell us in 10 years, but I'm going to wait for that. But the misuse were just phenomenal, because we had people trying to predict the day, hour, and seconds of the peak, whatever peak means, including a senator. So I guess one additional thing we have to think for that, your final slide, is how we build all of that in a way that those institutions are protected from political pressure or bad governance. Because if they are not protected, you know, then there you go. You have a phenomenal case study like Brazil, that everything went downhill because of the decisions that were made at the ministerial, at the presidential level and ministerial level.
Oh, thanks, Marcia. I have so many thoughts about what you just said. I mean, I think, yeah, it sounds like the Costa Rica and Hawaii case was practically spot on. Like, we're constantly afraid of losing the local trust and the relationships that we been building for quite some time. And I would say, yes, there was a challenge to try to argue that, you know, ours was more correct than, say, an outside model. That said, in Hawaii, there's quite a great deal of mistrust of outsiders. So in that sense, there's more trust naturally of local experts to begin with. I think that's probably also true for low and middle income countries to some extent. On the second point about the role of leadership and that's just sort of the politics and the governance, you know, I think there's probably different levels sort of on the spectrum of the government. You know, there were some people who were actively supportive. There were some people who were actively dismissive. And then there were just people in the middle who just like didn't really care. But if there were some people that had, if the dismissive people ran the whole show in Hawaii, it would have been a really bad situation. Fortunately, they didn't actively try to discredit us. It was always behind the scenes, but I can't imagine how that must have been. That must have been so challenging. Politics, I tell you, we should all go into politics, I guess, if we want to make our own community better. But I guess, you know, I don't know what solves democracy or authoritarian rule. I just, you know, we are part of the community that we build, and we can only do whatever we can, whatever small part we have to make our own community better. So, of course, being in Hawaii, we saw the confusion that was happening in Washington, D.C. and everywhere around the world. We thought, oh my God, we can't have that here in Hawaii. We tried as much as possible to prevent that, but inevitable, it snuck in. So trust absolutely is really important. But I've been thinking about it. I think it is an outcome. It's an outcome of the quality of the government and sort of the engagement between government and the scientific experts that, you know, in the end leads to some level of trust. It's not, I mean, trust, of course, is built over time, but there's some study that looked at sort of health. I think it was Tom Boyke looked at health COVID outcomes, and trust was a major determinant. But I think very much reverse causality. It's built over time. So
it takes time to build, but it's very
absolutely
fast to
very
totally destroy.
fast to just
Yeah.
very delicate thing. Trust.
Victoria, thank you so much. Are there any other questions that are?
I see a question in the chat from Jessica.
Okay.
And the behavioral expectations. I can, so amazingly, Jessica, I actually don't know all the details of the model. That would be a Monique Shiba question, and I can get back to you about it. But I think, you know, for the most part, it was not incorporated into the model. So we just sort of the behavioral expectations was not incorporated, and I think there's a lot more work that can and needs to be done to incorporate it. But yeah, for the most part, it was not directly incorporated.
I would submit, Victoria, that that outside models definitely don't incorporate that, because people are not embedded in the society, and therefore it's very easy for them to dismiss it. And I think that more than anything is why you need local development, both to incorporate that, as I say, is often missing, and because it also develops one's own sense of self, one's sense of self, which is oftentimes given over to outsiders because you feel inferior. You can't. How can I dismiss recommendations from Harvard or the Imperial College or
Absolutely.
God? So a sense of self is really, really important. And I think that last question gets Well, we've reached the hour, and I want to thank you, Victoria, for a terrific presentation and an excellent
much.
dialogue and discussion, which I think was really tremendous. I think that's what we all should strive for in all of these brown bags, where we get this vigorous kind of discussion going, because I think it was really important. And we look forward to your next visit up here, whenever that
you.
may be.
Hopefully soon.
And again, applause and thank you
Thank
all.
you so much, everyone, for your time.
Thank you.
very
Great
much.
to see you all.
Thank you.
Have a
Bye.
great day. Bye-bye.